Good morning. So the first topic for today is tight junction protein 2 and genetic cholestatic disorders. So a quick summary, I'll keep things a bit oversimplified, but let's see how it goes about. So bile synthesis, we all know that bile is synthesized from cholesterol in the hepatocytes, and then this bile salt is transported across the canalicular membrane. I'll just point out the canalicular membrane. This is the canalicular membrane, also known as apical membrane of hepatocyte, and the rest all is basolateral membrane. This is the lateral membrane, and two adjacent hepatocytes are close by here and are bound by tight junctions. This will come to frequently in the talk. So bile salt which is synthesized is transported out from the hepatocyte to the canaliculi with the help of ABCB11, that is also known as bile salt exporter pump. ABCB4 transports phosphatidylcholine, which keeps this bile salt dissolved in the form of a micelles. Now this bile is then goes across, and 95% of the bile is reabsorbed from the terminal ileum and through ASBT. This is apical sodium taurocolate transporter, and this bile salt is then again reabsorbed back into the hepatocyte through NTCP and OATP. NTCP and OATP are present on the basolateral membrane, which is adjacent to the sinusoids. So from the blood, the bile salt is reabsorbed, 95%, and 5% is excreted. So this would be the basis all throughout. Now if you see the expanded form of canalicular membrane, this side is hepatocyte, this side is canaliculi. So the ABCG5 transports cholesterol crystals out from hepatocyte to the biliary canaliculi. ABCB11 we saw that transports the bile salt. This bile salt is kept into a micelles form with the help of it forms a micelles. Bile salt plus phosphatidylcholine forms a micelles which keeps this cholesterol in a dissolved form. So if anything is defective, then this cholesterol will not be in a dissolved form, and it will be a lithogenic bile. So these transporters which are present at the canalicular membrane were what was initially described as the classical PFIC type 1, 2 and 3. So this were the one from BSEP defect was defined as PFIC2, where the bile salt which was formed was not going out into the canaliculi, accumulating in the hepatocytes and causing damage to the hepatocytes. Type 3 PFIC was MDR3 defect, where phosphatidylcholine was not going out, and hence the bile acids were not being in a dissolved form due to inadequate formation of micelles, and this bile acid was causing damage to the canaliculi. So this was a biliary form of disease. And then there is FIC1, which maintains the stability of the membrane, and the defect in FIC1 was known as PFIC1. These were the classical PFICs. So if you see this histopathology, this is from two of our patients. This is BSEP. This should ideally be present at the canalicular membrane, and this is absent in this patient from BSEP or type 2 PFIC. And this is MDR3 immunostaining. Again, this should be present at the canalicule membrane. This is absent in our patient, and this is PFIC type 3. Now there are other defects which are being identified with the advent of genetic diagnosis. Now one of the important ones are myo5B. Now myo5B is a transporter of BSEP which is synthesized in the Golgi bodies to the canalicular membrane. So any defect in myo5B will not translocate the BSEP to the canalicular membrane, and it will be found in the cytosol where it does not have a function. Similarly, KIF12 has a role in transport of MDR3, the transporter of MRP2, and also in the BSEP transporter. So the defect in myo5B and KIF12 will cause mislocalization. So you can see here that the BSEP is present, but it is localized in the subcanalicular membrane, and it is in the clumped form. So although it is there, it is not functional. Similarly, you can see here MDR3 is present, but is not functional. So this is what happens when there is a defect in myo5B or KIF12. Then there is FXR, which is the master regulator. Any defect in FXR will lead to damage to hepatocytes because of overaccumulation of bile acids in the hepatocytes. Now coming to the last part is the tight junction. So as I said earlier, that the two hepatocytes, adjacent hepatocytes, are bound by tight junctions. Now if you see an expanded form of this, the tight junctions have claudin proteins, which are transmembranous protein, and TJP, which is known as tight junction proteins, which bind these claudins to the actin cytoskeleton and thus maintain these tight junctions. So any defect in tight junction proteins or in USP53, which is also attached to tight junction protein, will lead to a defective tight junctions, leading to an altered blood-bile barrier, and bile can leak back into the circulation and back into the hepatocytes and cause toxicity to the hepatocytes. So our topic of interest today is the defect in tight junctions, particularly the TJP2. So the pathophysiology is not as simple as I said, that the bile leakage into the hepatocytes through the blood. So let's see what has been found. The first few animal models of TJP2 knockout were lethal to the mice and they could not study anything. But this was one of the earliest model in the knockout mice, where they showed that the TJP2 knockout, you can see that TJP2 has been knocked out from the 3 controls, is leading to a defect in or decrease in the amount of claudin 1, which was bound to the TJP2 as we saw in the previous diagram, but it did not affect the levels of claudin 2, 3, occludin and cingulin. You can see here that the claudin 1 in the wild type is present, whereas in the knockout type claudin 1 is decreased, whereas other proteins are similar. Does this affect jonation? So this we can see by CYP2E1, which is a marker of jonation, is present at the same place. So this does not affect jonation. And this is also showing that the claudin 1 is decreased in the TJP2 knockout mice. What else is happening? One is that there is altered cellular polarity. BSEP, which is a transporter which should be present at the apical membrane, and radixin is also a marker of apical membrane, were absent in the TJP2 knockout mice. The initial concept of the altered blood-bile barrier was possibly not happening, at least in the mice, as we can see that when we are giving dextran, we can see that the blood-bile barrier was not altered in the knockout mice, but when we altered the blood-bile barrier by administering lipopolysaccharide, then the blood-bile barrier was altered. TJP2 knockout also leads to decreased transporters, down-regulation of the transporters, and the detoxification enzymes like CYP2B10 and NTCP and OSCP. Now this is one of the most recent studies where they have used the induced pluripotent stem cells and the CRISPR-Cas technology. I'll just take a minute here. Now they took PBMC from a healthy donor and from a TJP2 patient. From the TJP2 patient, from the PBMC, they made a iPSC and then allowed it to differentiate into a hepatocyte-like cell. Similarly, from a healthy donor, they prepared a iPSC and then using CRISPR-Cas editing technology, they changed this C to T, which leads to a termination codon after 367. So it leads to after arginine at the 367 position, there is a stop codon. So CRISPR-Cas technology they used and created a TJP2 knockout iPSC and then allowed it to differentiate into hepatocyte. And this normal iPSC served as a control. Normal hepatocyte-like cell served as a control. Now we have 3. One, a normal cell, a normal hepatocyte-like cell derived from a healthy donor. One derived by CRISPR-Cas editing, and one from a patient directly. Now what we can see, again confirming the finding that we have seen in the mouse study, that radixin which should have been found at the apical membrane is absent in both the knockout and from the patient's hepatocyte-like cells. Similarly, claudin 1 which was present here at the near the tight junctions, is absent in both of these. Similarly, BSEP, which is a apical membrane transporter, which should have been present at the apical membrane, the green part, is now present in the clumped form in the cytosol in both these knockout as well as in the PFIC patient-derived hepatocyte-like cells. Now this is an electron microscopy structure. The normal canalicular membrane should have looked like this with microvilli and the microtubules also just in the subcanalicular membrane. And here we can see that the microvilli structure is altered in the TJP2 knockout hepatocyte-like cells, and we can see that the microtubules are in a clumped form in form of intracellular vesicles in both these cases. To confirm this, they also did it in the liver tissue from a healthy donor and from a TJP2 deficient patient. Now this is directly from a liver biopsy, not from a hepatocyte-like cells, which is this. So you can see that these are the tight junctions, the black one, and this is the canaliculi, and in the canaliculi they are villi, microvilli. Now in this TJP2 patient, we can see that this canalicula is almost destroyed. All this microvilli are present in the clumped form, and the tight junction proteins are abnormal here. So, and the last part is the impaired directional bile acid transport. So this is a transwell membrane. Normally the bile should flow from lower to upper chamber, that represents the basolateral membrane, to the apical membrane, which is happening in the wild type hepatocyte-like cell, whereas in the knockout, as in the PFIC patient, this transport is altered. And if the bile is flowing from the upper to lower, that is representative from apical to basolateral, that is a reverse or leakage of bile, which is happening in the two PFIC knockout and TJP2 knockout and the PFIC patients. So to summarize, the pathophysiology in TJP2 is there is an impaired blood-bile barrier, which was initially thought as the only possibility. But what we have seen is there is altered cellular polarity. So bile is not exactly flowing from the basolateral membrane towards the apical membrane, and the transporters which should have been present at the apical membrane are present in the subcanalicular space in the form of intracellular vesicles clumped. There is disrupted localization of the transporters like BCEP and NTCP. There is disruption of the membrane, and there is impaired directional bile acid transport. So what will all this lead to? What will be the clinical features of these patients? So before coming to the hepatic clinical features, I'd like to point out that tight junction proteins are part of all the cells which have tight junctions. So as you can see in the various types of PFIC, if we take the TJP2, this is expressed in almost all cells like liver, pancreas, terminal ileum, colon, even lung and brain. So tight junction proteins are expressed in almost all tissues, and hence TJP2 disease can be associated with several extrahepatic manifestations like impaired myelination, myopia, sensory neural deafness. Whether they are due to impaired myelination, we don't know as yet. Respiratory problems in the form of recurrent wheeze, neuromuscular weakness, chronic diarrhea, and renal tubular dysfunction. What has also been described in few case series is predilection to SCC at a very early age, as early as 6 months of age, even when the liver has not completely become cirrhotic. We don't yet know how TJP2 deficiency causes hepatic carcinogenesis, but there are papers to show that TJP2 inhibits the Wnt signaling pathway and reduces cell proliferation and promotes apoptosis. So TJP2, in addition to its function in tight junction protein, also has functions in the nucleus, where it acts by inhibiting cell proliferation and blocking the cell cycle progression. So any impairment in TJP2 is likely to increase the risk of carcinogenesis. So what do we know about the clinical presentation of TJP2 so far? There are only 4 case series till now. The first and the earliest and the largest one was by Samrota et al. In 2014, where they did the whole exome sequencing of 12 patients who did not have a genetic diagnosis on the basis of targeted genome sequencing, checking for PFIC 1, 2 and 3, which were known at that time point. And they found that the defects in TJP2 were present in all these 12 patients. Now, a very typical feature was early onset jaundice, pruritus, and a very rapidly progressive course. 9 out of their 12 patients required liver transplantation, 1 died, and only 2 were surviving with a native liver at the time of reporting of their cases at 4 and 7 years of age respectively. But with time, there have been further case series which have described that the outcome is not always that bad as described by Samrota et al. And this study from the Chinese group in 2020 showed in 7 patients there was varied phenotype, but whatever the phenotype, all the 7 patients were surviving at the last follow-up, but none of these follow-up had been shown beyond 4 years of age. There are other studies, and there is one report from India, case series from India, but this case series was a liver transplant case series in TJP2, hence all 4 patients had received a liver transplant. To overcome this lacuna in literature, we decided to evaluate TJP2 as we are already looking after the Indian PFIC registry. So I'd bring out most of the data, the new data from the registry that we are maintaining at ILBS. So Indian PFIC registry right now, ILBS is the nodal center, and we have 17 centers on board This was till September 2023. Now we have around 19. And we had a total of 304 cases of genetically confirmed PFIC from different centers. Now if you see the distribution, we can see that as expected, BSEP is the commonest PFIC followed by MDR3, but TJP2 is the third most common cause of genetic intrahepatic cholestasis in India. We had 47 patients out of 282. Now let's see what is the clinical outcome natural course of these 47 patients. So out of these 47 patients, I will be describing the findings in 44 patients with likely pathogenic variants in TJP2 gene, 25 of whom are homozygous and 19 of whom are compound heterozygous. So if we see the clinical presentation of these 44 children from India, from 39 families, consanguinity was present in 34. Most importantly, 90% presented with jaundice, and the median age of presentation of jaundice was 2 months. So TJP2 presents with very early onset cholestasis. 66% present with the jaundice within first 3 months of life. Pruritus is seen in almost more than 3/4 of the cases, and of those who have pruritus, around 2/3 have severe debilitating grade 3 or 4 pruritus. Growth failure was present in about a half of patients, and extrahepatic manifestations were not very common in our patients. 7 out of 44, that is about 1/6 of the cases, had some extrahepatic manifestations.
Just hold on to the previous slide. So what age did the gallstone come up? This slide?
This gallstone was family history of gallstones, sir. So it was I have to check. I cannot be sure, but this is in the adult family members of these children. So exact age I am not sure. And this data was not collected.
None of the patients had gallstones. None of the patients had gallstones.
Patients, no, sir. Patients, extrahepatic, no, sir. No, none of the patients had gallstones.
Okay.
This was only in the family. So if you see the biochemical variables, almost all of these cases will have elevated serum bile acids, which should be a part of the standard liver biochemical test which we do at admission. Ascites was present in 34. The important point is, those who developed ascites develop it at a very early age. The median age of development of ascites was just 2 years. So the cirrhosis is very rapidly progressive in these cases, and portal hypertension is also rapidly progressive, as evident by 15% of patients having variceal bleed. Surprisingly, none of our patients had hepatocellular carcinoma, including in the explant which will be showing. Coming to the outcome, at a median follow-up age of 57 months, 54% were surviving with the native liver, while the rest 50% had either died or had received liver transplantation. Of those who died, and the median age at death was around 2 years. Coming to the histopathology. Now this is not from our patient, this histopathology is from a paper. So we can see here that TJP2, which this is the control, we can see that TJP2 should be present somewhere close to the canalicular membrane, as it is present in the tight junctions. And here the patient is lacking TJP2. And TJP2 binds to claudin 1, so claudin 1 immunostaining is also decreased in the patient. Now we have TJP2 immunostaining in our in our pathology department, and which soon after standardization we should be able to start. Now what was the histopathological finding in our cohort of 44 patients? We had liver biopsy in 31 patients and a histopathology in 37, of which 31 were liver biopsy. The median age at liver biopsy was 12 months, and this was a peculiar new finding in our 44 cases, that 9 out of 31, that is 30%, has paucity of interlobular bile ducts. So this disease is just not affecting the hepatocytes but also affecting the small interlobular bile ducts. And 42% had already had advanced fibrosis F3, F4 by around 12 months of time. So cirrhosis is rapidly progression, and wherever we had a paired biopsy from the liver biopsy to the explant, there was always progression to the cirrhosis at explant. Now coming to the most interesting part of this TJP2 thing is genotype-phenotype correlation. Unlike most of the diseases which do not have a genotype-phenotype correlation, including all other types of PFICs, this has a very typical finding. So what did we do? We categorized the genotype into three types: TJP2A, TJP2B and TJP2C. I will take some time here to explain what is TJP2A, 2B and 2C. TJP2A is when there is missense variant on both the alleles. So that is a homozygous patient. So sample this for a report of one of our patient. So what do we get a report like this when we sent it to the genetic lab. TJP2 is there is a variant in the TJP2 which is present on exon 18. We need to see this part. What is the variant? The C means the nucleotide change. 2549 means the position at which the nucleotide has changed. T nucleotide has changed to C. Now we also need to see what is the change in protein in the amino acid. So P means change in amino acid. So leucine has changed to proline at 850 position. Now if one amino acid has changed to another amino acid, we call it a missense variant, and it has happened on both the alleles as the patient is homozygous. So we label such cases as TJP2A. Now this is a definition, this is the classification which we have done for this manuscript, which is under revision in hepatology. So another example for this could be something like this: 1760G2A, where glycine amino acid is changed to aspartate at 587. So this was given nomenclature as TJP2A. Now what is 2C? When there is predicted protein truncating mutation on both the alleles. What do I mean when I say predicted protein truncating mutation? So sample this for one of our patients who has undergone liver transplantation. TJP2 has a variant. The variant is 2686C to T. Now it appears like it is a missense because one nucleotide is changing to another. But look what is happening in the amino acids. The arginine, after arginine, TER means termination. The protein is stopping at that amino acid. There is no further protein. So this is a protein truncating mutation. Although this is a single nucleotide variation, this is leading to protein truncation. So this is an example of PPTM on both the alleles. So this is TJP2C. Another example of TJP2C could be like this. It could be just a deletion after 2988. So this is a frame shift termination codon after 997. So these were given as label of TJP2C. And if there was a missense variant on one allele and a PPTM on another allele, it was given nomenclature as TJP2B. So finally, 47% patients were 2A, 16 patients were 2C, and 7 patients were 2B. Now let's see what happened to our TJP2C patients. There were 16 patients with TJP2C, and of these you can see almost all have died or have received liver transplant at very young age, 18 months, 26 months, 4.5 years, 5 years, 12 months, and so on. And only 2 patients, patient number 15 and 16, are surviving with their native liver at present. And of this, patient number 15 is already listed for liver transplant for progressive jaundice and refractory pruritus at 18 months of age. So basically, only this child who had undergone a partial internal biliary diversion at another hospital in Delhi, but thereafter is following up with us, is surviving with his native liver at 14 years. So basically, we have only one survivor among 16 patients with TJP2C reported from India in our registry.
Just to stop you, this is such an exciting data. How many developed portal hypertension and at what age? Out of your 16, I see many have not developed portal hypertension. Is this correct?
No, sir. I think almost all of them have developed portal hypertension because they have developed ascites and progressive jaundice, ascites, and
so the natural history is through portal hypertension, fibrosis, cirrhosis,
yes,
and portal hypertension,
yes,
needing LT.
Yes, so this is also because what I showed in the histopathology that all the explants, by the time of explant, they had developed cirrhosis, and high number of patients had this variceal bleed. So definitely this progression is a rapid progression of cirrhosis.
Okay, go ahead, please.
Now, in contrast to what I showed in the previous slide, see what is happening with TJP2A. Now, this is one of the most common mutations that we have found in India. Patients number 31 to 39, 9 patients, all of them have same mutation. The numbers are different here, but they are actually the same mutation because The reporting has changed over the last like 3-4 years, and different transcripts use different number. But basically all of them are having a change from leucine to proline. So this TJP2A, 9 patients with the same mutation, you can see that all of them are surviving with their native liver for as long as 10 years and 13.5 years. So if we compare the patients with TJP2A and 2B, we have combined together because their outcome was similar, compared to TJP2C, we see that TJP2C had much earlier onset of jaundice, were less likely to resolve their jaundice, were less likely to resolve their pruritus, were more likely to develop early onset ascites, and when they developed ascites, this ascites came much early. You can see that the age at onset of ascites was 18 months in 2C versus 96 months in 2A and 2B. Portal hypertension was present in 83.3%, but this could also be biased, and I believe it should be 100%. It could be reporting bias because it is a multicentric data collection. And serum bile acids were much higher in TJP2C and PELD were much higher in TJP2C. What about the outcome? As I already showed, that out of 16 patients, only 2 are surviving with their native liver, and even one of them is still listed for liver transplantation, and 14 of them have either died or received liver transplantation. Compared to 2A and 2B, where 78% of patients are surviving with their native liver at the last follow-up of around 6 to 7 years, median of around 6 to 7 years. Also important to note that age at death or LT was, when they were dying at a much earlier age. That is 2.5 years was the median age of death or LT in 2C, where it was 9 years in TJP2A and 2B. So this is confirmed in this Kaplan-Meier analysis, which shows TJP2C, the native liver survival is much worse compared to 2B and 2A. And this is the overall survival with or without liver transplant. Even then, the overall survival in 2C was worse as compared to TJP2A. Now, this is an analysis where we have combined all the reported cases in the literature till date and tried to find if actually this is just in India or this is actually a genotype-phenotype correlation all over the world. We have also wanted to look whether HCC is affected by the genotype. So, we have totally collected 72 cases, and of the 72 cases, 40 cases were 2C and 32 were 2A and 2B. And what we see is the odds ratio of death was 9 times, and HCC developed in 4 patients and only developed in TJP2C and did not develop in any patient with 2A and 2B reported in literature till date. I would like, as shortage of time, I'll just quickly go through. This is the pruritus management. So we can do biliary diversion in TJP2 patients, and outcomes are good if the response to PIBD, partial internal biliary diversion, is good. Liver transplantation, typical indications, no specific post-LT complication, no specific extrahepatic manifestations post-liver transplant. So outcomes post-LT are good. Just a word about TJP2 in adults. Although we all believe and all the literature is pointing that TJP2C will present in children, there is one study in literature which shows that homozygous termination, this PPTM can present even in adults, where they showed that one family who had 12 children from Denmark, 2 of these had cirrhosis, but 2 patients just presented with elevated liver enzyme despite having homozygous mutation in TJP2C. Also, TJP2 heterozygous patients can present with ICP, as evident in this study in patients with where they showed that 3 patients out of 26 had heterozygous mutation in TJP2C. IBAT inhibitors is coming up in a big way for management of these patients, and for the shortage of time I'll skip. But yes, if you have a genetic diagnosis, look for whether it is TJP2C or 2A and 2B. If it is 2C, you know the child is not going to make it to his 5th birthday, and so you should list them early for DDLT and counsel and prepare for LDLT and do a more aggressive nutritional rehabilitation in these patients. So to conclude, TJP2 deficiency acts by impairing the blood-bile barrier, altering the cellular polarity, disrupting the transporters and the apical canalicular membrane. The clinical course has cholestasis in early infancy, and there is excellent genotype-phenotype correlation. Post-LT outcomes are good, and HCC is uncommon in Indian population. Thank you.